back hear me? We're good? So if I don't use a mic to project you, I'm good, yes? Okay. Those I've not had the pleasure of meeting, I'm Dr. Thomas Parham. I am a psychologist by training, formerly Assistant Vice Chancellor for all the wellness, health, and counseling things we do at the University of California, Irvine. I now am the Vice Chancellor for Student Affairs, and also serve, as you heard this morning, on the System-Wide Mental Health Oversight Committee. So mental health is really a passion of mine. I'm one of those people who is both an academician, a clinician, a researcher, and of course I now do administration as well. So I come at this issue of mental health from a lot of different sides. I want to invite folk, if you are in the back, to think about moving up, just because sometimes the print gets small. So if you want to see it, whatever, please feel free. Let us shrink the size of the room so we can have some dialogue. I'm going to try to talk a little faster than I normally would, because we have about an hour and a half to be in here that's now been reduced to about an hour 25. So I'm going to try to get through as much of this as we can, and then begin to kind of take questions and have some dialogue with you about that. That good? Okay. So I want to begin by looking at this background here. Can you see, by the way, this red laser from back there? Okay, all right. So this background here, I want you to take your mental health hats off for a moment. And I want you to think about being architects. And in your architectural hats, if you had to describe these columns here in this architecture, what comes to mind? Somebody tell me, if you were architecture, you're a real estate agent, you're about to sell a house, and you see some columns like that, something ought to come to mind for you to describe to your clients about what kind of architecture that is. Somebody tell me.
Support?
So cultural, I'm thinking cultural. Where does that come from? So Greco-Roman, right? Typically the answer you get. Now, why I ask that question is because if I could illustrate for you a timeline of human history, with the zero line being here, 2014 being at the bottom, and I could go back, Greece and Rome get on the planet, right? 4 to 500, 300 BC. This particular structure here is the perimeter outline for space in Sakata that houses the step pyramid. So it's the outside perimeter. It is 2,750 years BC, nearly 5,000 years old. Greece and Rome are not even on the planet yet. Now, why do I use this as a moniker? Because what the ancients built, this and then the step pyramid that I'll show you before, is something that has lasted 5,000 years. And I use that to kind of frame the discussion and the narrative we have this afternoon, because when we talk about developing levels of cultural competence within the context of our mental health service, what I want to do is invite you to avoid doing things that are just temporal and fashionable in the moment. What we're not interested in doing is doing what I call democratic sanity. Just because everybody's doing it now, we'll all embrace it and now do it, and then 2 years later we're doing something different. So the title of the presentation literally is called Building for Eternity. What the ancients were able to do is build for eternity. We build structures now, 30, 40 years old, 50 years old, 60 years old. We're blowing up arenas because they're all dilapidated, tearing down, houses termite ridden. How do you build stuff that's 5,000 years old and still stands? Because they built for eternity. If we're going to build a psychology and a mental health practice, then we have to build things that will last over time. That is what we are about trying to do. Everybody with me on that? Okay. So when I think about the assumptions we make, I'll begin with actually 6 of them. The first 3 are, if the foundation of our individual, institutional, organizational, and societal competence is not anchored in values that contribute to the cultivation of the human spirit, then what we build will not sustain itself over time. Let me say that again. If the foundation of our cultural competence and all the things we do does not contribute to the cultivation of the human spirit and the human potential, then what we build won't last over time. Secondly, I assume that the identity of a truly competent professional can never be anchored in notions of material acquisition. Now, I'm not just talking about finance and cars and money here, because the material capital that we use to certify that all of us are competent is what? Somebody tell me. Degrees, exactly right. So as soon as we get our degrees and certifications, we're certified. And I'm here to tell you today, right, that degrees do not necessarily make you culturally competent. Degrees do not necessarily make us culturally competent. So we have to invite ourselves to think about what is competence within a broader context than just the degrees and certifications that we get. Thirdly, building for eternity, as best I can determine, is I go and study all the ancients. And I've actually been to this place, so I took this picture right here. The ancients had a formula. And almost every formula I can find for how they built structures like this and the pyramids at Giza and other places is, they had an excellent design, preparation and construction on one hand, and an aspiration to harmonize with divine intent on the other. Everything they built was built with divine intent. Every temple, every tomb, every pyramid, every whatever, all had some kind of divine intent. So if we're going to build for eternity, I think those are some of the ingredients that you have to be able to have. Excellent materials, preparation and construction, and an aspiration to harmonize with divine intent. Number 4, I assume that legitimate theories of cultural diversity and cultural competence can never be anchored in constructs that don't fundamentally support and affirm the humanity of our patient populations. Now, why is that important? Who's a mental health professional here? Psychologist, counselor, something. Okay? Who works in any kind of allied mental health profession like social work? Where are we at? Social workers? Okay, counselors, nurses, disability specialists. Okay? Who else do we have? Who am I missing? Okay?
I'm a member of a behavioral evaluation.
Behavioral evaluation team. Okay. All right. So behavioral health. Who else we got? Yes?
Academic advising.
You're academic advising. Okay. All right. Who else we got?
Student conduct?
Student conduct. Oh, you all definitely need to be up in here, huh? For all of us who manage student conduct. So good. But any theory that you develop, I would argue, can never be anchored in constructs that fundamentally don't support and affirm the humanity of your populations. Also, training to be a culturally competent individual cannot be done in 25 words or less without commercial interruption. You can't go to one seminar or read one book or do, it takes time. And as Joe White was saying, your theoretical knowledge has to be able to blend with the practical experience where you're engaging folk to really learn and get better in that competence thing. We'll talk about that later on today. And also, to me, there's a fundamental difference between, skin color and consciousness and skin color and competence. Why is that important? Because in our efforts to be more culturally competent, one of the things that institutions do is they try to desegregate their staffs. So when we didn't used to have any black folk, now we got black folk. Didn't used to have women, now we have more women. Didn't used to have gay folk, now we have gay folk. Didn't used to have, disabled folk, now we got disabled folk. Didn't used to have blah, 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 whatever the demographic is. But because you represent a particular demographic does not necessarily, by virtue of that demographic, make you competent to work with those populations. And part of what we have to do a better job of, if we're going to really promote cultural competence, is do a better job of screening folk on the front side and even providing continuing education, in their roles, so that we're not simply looking at, whether or not I happen to be black so I necessarily can work with black clients. Being black doesn't necessarily entitle me to be able to be competent to work with anybody. It takes a lot of training, a lot of hard work, a lot of whatever, for whatever demographic that we represent. We with me on that? Okay. So those are some of the assumptions that you'll see me make and hear me make in the context of this presentation. Now, if we're talking about competence, let's define competence for me. All competence is to me are skills and attributes that allow you to effectively intervene on the demands of a particular situation or circumstance. That's all it is. What is your tools? What is your strategies? What are the elements that you can bring to bear on a situation to help you achieve a particular outcome? That's all a competency is. So when we talk about that, what I want to do is help us move, and I'll show you a little chart on this in a minute, from talking about competence to one that really embraces proficiency. Because proficiency is different than competence. And it is different is that proficiency requires not only consistency over time, but consistency with a standard of excellence. Not just I can do it and be competent with it. So what I'm trying to really promote is this whole notion of proficiency here. Now, what competency in mental health requires, I think, having been traditionally trained, is being able to free ourselves from traditional definitions of what counseling and therapy and mental health look like. You've got to be able to step outside those boundaries. You've got to be able to expand your boundaries of professional practice. You've got to be able to expand and utilize alternate helping roles so that you can't just be relegated to, as Joe White was saying this morning, the 50-minute hour or the one group and assume that somehow that'll meet all the needs of your client. I love folk now who are doing work in learning from indigenous models of helping. Like our psychology is relatively new compared to the age of the world. So how is it that cultures have been getting along all these thousands of years and their mental health has been fine? What do we have to learn from indigenous models of helping? Also, competency requires a high degree of congruence between our ethical standards and professional behavior. So I think ethics have to inform the way in which we work in ways that are different than I think what it is we do now in mental health. But also, competence requires challenging our biases and assumptions that we carry with us every day. When we get to the models of cultural competence, we'll introduce you to the different stages of that you'll see my colleagues like Daryl Sue and others begin to put out there. But they don't start with skill and knowledge. They start with something, I think, a little deeper, which is our awareness about the biases and assumptions we bring with us into the space. So I would argue that competency requires these and more things. Now, we're always interested in metrics. So if in fact we are culturally competent and we're doing good work, then I think the goal of culturally competent practice in all of the domains that we talk about, whether we are doing behavioral health interventions, we're in mental health centers, we are in hospitals, we are in psychiatric inpatient facilities. The goal in being in any of those facilities ought to be that the client's mental health that we're working with ought to improve. Yes? The goal ought to be that clients who represent particular groups that have been traditionally disenfranchised or underrepresented in the counseling profession will be more likely to seek treatment from your facility than they would otherwise have been. So if you're sitting on 10% demographics in a particular population, but 1% of your client base, you either have to assume that that client base is more mentally healthy than the rest of the broader population, or there's something about your service that's not attracting them to be able to get there. I would assume probably the latter rather than the former. Talent, like mental health, like mental illness, is equally distributed across whatever demographic you can think of. I also invite folks to remember that clients ought to receive culturally appropriate therapy and service. The goal of having culturally competent service ought to be that we treat folk in culturally competent ways. What ought to happen? That more than ever before, clients will be retained in treatment. Why is this important? Because the story that Joe White gave about a student in 1959 is very indicative of what goes on in our mental health treatment centers today, even on our college campuses. Most folk who are culturally different, who could benefit from any kind of mental health treatment and therapy, don't get it. Of those who do come in, most of them terminate treatment after what? Time 10? Time 5? Time 3? Time what? Time 1. What is it that we are not doing in our mental health care that doesn't allow the clients to have enough confidence that they even come back after the first session. And part of what happens in our notes is, we get very good at projecting onto other people. So client resistant, unmotivated for treatment. We have lots of different attributions we make about why people, come back. But rarely does the finger go this way to say, what can I do differently? If Michael Jackson said anything worth repeating, I don't repeat much Michael Jackson say, but love that brother's heart, God bless him. But he made a song called The Man in the Mirror. Said, if you want to make the world a better place, do what? Take a look at yourself and make a change. I'm looking at the man and the woman in the mirror. Also, I think that our assessment tools ought to be more culturally valid and only used when they're culturally appropriate. Now, our ethical guidelines ought to tell us that, yes? Except we violate ethics every day using some of the instruments that we use when they're standardized on the general population, but not normally standardized on the specific populations that we're applying them to. That training in culturally competent folk in counseling and therapy ought to be relevant, right, for learners and the communities that are being served. So how does what we do impact not only the individuals that we serve in treatment, but also the broader community as a whole? And also, if we're being effective at what we do, then the research that we perform and the data we create ought to inform, right, some relevant strategies or changes within the broader communities that are there as well. So if we're doing good work, I think these ought to be things that we ought to be able to measure and that ought to happen. Anybody got any more metrics they want to throw out here? If you're culturally competent, what ought to be happening? Yeah.
Impact on the community.
Say that again?
Impact on the community.
Right.
That's what I think.
So the impact on the community ought to be for these last two things here that I'm talking about. Exactly right. Any others? Okay, hearing none, let's keep on going. So what I want to talk about for a moment is the need for a culturally different worldview than lots of us have been used to. I'll start here on the left side of the screen. This is what we call the Eurocentric worldview. It is a fancy way of saying that most of the theories and constructs that we use in traditional mental health were developed by and for primarily brothers and sisters in the white community. Now, is there anything wrong with brothers and sisters in the white community speaking on their own reality? Anything wrong with that? No. So hear me well. The problem is not in the theory. The problem is in the application. Because when you take theories that are developed on one population and you apply them to other folk, those folk always come out looking very pathological. And when we're talking about African American folk in this case, they come out weakness dominated and inferiority oriented. Now, in that application, I want you to focus on the top, right, left hand of this slide. Because there are three problems if you're keeping notes. The first problem is that Eurocentric standards say we are the standard, we are the norm against which everybody else is measured. That's one application problem. The second issue is they assume that the norm is generalizable to everybody. So when we employ these theories, whether they're about mental health, human development, student development, whatever, right? IQ, all that. When we employ any of those theories, we assume that the norms are generalizable to all the patient populations that we see. Not necessarily an assumption I would embrace. And third, and perhaps most important, so if you're keeping score, you want to put an asterisk by this one. The Eurocentric tradition has a tendency to employ what I call a difference equals deficiency logic. What does that mean? It means that if I am seeing, right, Irvine, right? And Irvine comes in, and we're in some kind of mental health interaction here. He could share things with me. I could observe things in him. And I could say, maybe what I'm seeing out of Irvine is beyond, right, what my theory can accommodate. Maybe my theory lacks sufficient explanatory constructs to account for the phenomena I'm seeing. Is that typically what we do? Not even close. The typical response we use is, if what he says if how he responds is outside of this cultural norm, then I have a way of pathologizing, right, what goes on there. What I'm trying to do is invite us to consider that if you're only using one particular cultural worldview as the frame, as the lens through which normal, right, is measured, you've got to be able to expand this in a way in which we talked about earlier in those assumptions. Everybody with me on that? Yes, no? Give me something in the back. We're good? Okay. Now, I take us over to this center circle here. And I want to talk about this culturally assimilated model. So whether you are African American, whether you are Chicano Latino, whether you are Asian American, whether you are Native American, whatever, this is that space that is related to that particular group here. So that as mental health has become more culturally sensitive, hadn't quite got there yet, but more than they used to be, they've begun to extract knowledge out of this space. But the knowledge that they get is very stereotypic. And in some cases, I would call, at least in respect to black folks, since we're talking about black folks today, that knowledge is what I call very ghetto-centric. Now, why do I say that? One of the things I used to teach my students as a professor is when they would study for exams, lots of us did, right? You want to review a massive amount of articles in a short period of time, so what do? You go read the introduction, and then where do you fast forward to? The conclusion, right? And you miss all the stuff in the middle. I teach my students to start in the middle, because the first place they have to start is in the methodology section. Because I want to know who they studied, what they used to study in, what the research design was, what statistical analysis they used, because I need to know how credible the research is that the conclusions are based on. And once I can tell what is the population sample, where did it come from? Most of the theories and constructs that are developed in the African American community are done on southern-born, working-class, ghetto-dwelling black folk. And then we extrapolate from that population to the whole. Even for our Mexican-American brothers and sisters, right? Latino brothers and sisters who live in lots of different places. The information that you can find out in the literature is very stereotypic. So you've got to be able to move beyond those particular frames to understand that the population is much broader than that, right? So what are we saying? What Joe White argued when he wrote, since they were talking about him this morning, Toward a Black Psychology, is that if you're going to develop a psychology of a people, that psychology has to emerge out of the authentic experience of black folk within the whole spectrum. So when you're talking about not just here, I'm not saying there aren't some ghetto-dwelling black folk in life. That's true, yes? I'm saying that's not the whole community. So if you're going to develop a psychology, you got to develop a psychology out of all of this, not just the one piece. Who would agree? Okay, all of us, all right? So that's point two we want to be able to make with this. That you've got to be able to be more encompassing and not just rely on stereotypic information from your theories, but be able to get here. Now, here's a question. What we do as mental health professionals is try to define and describe what is normal. Yes? Our job is to define that reality. So, if you're developing a theory, even according to Joe White, based upon the authentic experience of folk in this whole circle, are you really developing theories of health and wholeness that are indigenous to the culture? Or are you really developing theories based upon ways in which people have adapted to 350 to 400 years of their sojourn in the country? What do you think? Say that? Adaption. So, what some people do is they say, we can't go here with the theory, we got to go way over here. So this third circle you're looking at that I call the culturally different circle, these are the indigenous models of healing and practice. So if you want to study what is indigenous to African people, go back and study indigenous African culture. If you want to know what's indigenous to Latino folk, Asian folk, go back and study indigenous cultures. Because there you can find some models and methods that might inform the practice that you provide. Why is that important? Because if you go and pick up a book, any topic, about cultural competence and working with a particular group, you have to be sophisticated enough to know not that you're just reading a book about black psychology and mental health and black folk, but you got to know, does that practitioner or scholar come out of this base, out of this base, or out of this base? Because the assumptions that he or she makes inform and shape the strategies that they will then recommend. But if you're just taking those lock, stock, and barrel without knowing this level of sophistication in here, those are totally different strategies that have a different level of utility for some of the populations that we're trying to work with. Y'all feeling me? Now, commonsensically we know all black folk aren't alike. But we act as if they are when we look at some of the research that's done, because we put folk in these kind of discrete categories, right, of demographic information. What I'm trying to do is invite you, in terms of developing different levels of cultural competence, if we're going to build for eternity, is you got to be more sophisticated in looking at and absorbing information in books you read, articles that you quote and cite, because you got to understand what particular perspective is this individual coming from. When you get in presentations, you got to be able to interrogate what they do. If you look at some of my work, for example, I don't know, 6, 7 books by now and about 45 or 50 journal articles, but a lot of my stuff came out of here early. And lots of my recent stuff now comes out of this particular square. And that's kind of the developmental process that I've made. But you could find that out by just talking to somebody like me. But if you aren't talking to these scholars, so for example, if you aren't looking, who does some great work is my colleague Daryl Sue. So Daryl, who does lots of good work, comes out of this particular space. But if you haven't read some of Christina Ye's work, who does some great work on working with Asian Americans and indigenous healing practices, she's in this particular square. But if you're only promoting Daryl and quoting Daryl, you miss a whole bunch that goes on in these other spaces here. Okay, everybody with me on that? Okay, questions so far? Back here, yes sir, Irvine.
It's safe to say, when we're looking at cultural difference, that maybe that's where they're taking into account how people of different color, if you will, culturally assimilate being American. A black man might do it differently, or be assimilated in a different way than a white man or a brown man.
Yes.
So they're sort of combining the two?
Yes.
Cognizant of at least the differences.
But remember, the one of the challenges I have, and I didn't see it till much later in my career, but using some of the information that's in this center space here, is that adaptation is not necessarily, right, what you want to be focused on. That's democratic sanity to me. Remember, as psychologists and mental health providers, what's the central question we started this particular slide with? Our job is to speak on what is what? Normal and healthy, not adaptive. So my question then becomes to you, I'm an African American patient who comes to you for therapy. And I come to your counseling center, your advising center, your treatment plan, right? You have a behavioral intervention team that's developing strategies to work with folk like me. Your job, if I have any kind of mild, moderate, or severe debilitation, is to help restore me to some level of health and wholeness. Yes? My question to you is, how do you help someone like me, as an African American male student on your campuses, in your treatment facilities, in your hospitals, to be mentally healthy? That's the question, yes? If you have no idea about what constitutes mental health for African people. Remember Arsenio Hall, these are things that make you go, How do you help me to be mentally healthy? How do you help some brother or sister who is GLBT to be mentally healthy if you have no idea about what constitutes mental health for somebody who's gay, lesbian, bisexual, or transgender? How do you help a Latino brother or sister to be mentally healthy if you don't understand what mental health is in the Latino community? One of the assumptions we make is that it must all be the same as this stuff because these are the universal personality theories we use. But I can tell you for sure, The reason that we misdiagnose, right, and mistreat lots of folk is because the assumptions we make using this are down in here. And we come out, right, pathology driven, and then the consequence is the kind of treatment we provide. Even in our counseling centers, by the way, which ought to be the most culturally competent spaces there. Because counseling discipline, right, compared to my clinical counterparts can't spell cultural competence. And I'm in APA every year. I know them all, know what they write. I write the textbooks people use to teach black psychology. I understand. But most of the good work that's come out of the counseling profession, not the clinical one. That's why Joe White was talking about that this morning. But even at that, we've got to be able to grow and advance beyond where our base knowledge is. And if you aren't incorporating some of these practices, you got to know. But if you're citing this work again, you got to know, is your theorist coming out of this space, out of this space, or out of this space? Because they make a big difference in terms of the strategies that they'll recommend, right? And those that you're prepared to employ in working with the populations that you have. Everybody with me? Okay, let's keep moving. So let's talk about culture now. If I say to you, your agency is not very culturally diverse, somebody ought to be able to say, oh, Parham, you tripping. And I'd say, prove it. How would you prove it? Your agency is not very culturally diverse. How would you prove that it was? Oh, Parham, you lying. We are real diverse. How would you prove it?
I think typically we would look at our staff and say,
Parham, you tripping, right,
But-
because we got 5% and 10% and 15%, exactly right.
but that probably doesn't qualify truly as being diverse.
I would think there's a difference to me between a desegregated environment and a truly integrated one. I'll make that note later on. You hearing me? There's a difference between a desegregated environment and an integrated one. What we practice in oftentimes are desegregated environments, not necessarily integrated ones. How would you prove it? Parham, you lying because look at all the cultural celebrations we do. And you wouldn't have a cultural celebration. How many of us throw cultural celebrations in our agencies? Yes, where we at? Nobody admitted now, right? Everybody's like, no, right? And we wouldn't have a cultural celebration without having, right, food, and we wouldn't have without having music, right? And sometimes we do dance and dress and clothing. And if we're really hip and cool, we have like holidays for good measure. What I want to invite you to consider is that those are manifestations of culture, but they are not culture in and of themselves. If you really want to understand what culture is at the deep structure level, let me invite you to put your snorkeling gear on and let's kind of, get out into the water for a moment. Then we're going to take a deep dive. Culture unifies and orders our experience because it provides a worldview that orients our experience and interpretation of reality. Imagine yourself putting on a set of lenses and glasses that color and shape your perception of what you see. Culture helps inform and provide that. It provides collective group identification that is built on shared history, is built on shared symbols, and is built on shared meaning. So why is it that two people can look at exactly the same incident and come out with very different interpretations? Because there's a cultural lens that they are filtering that experience through. We've got to be able to understand what culture is. Thirdly, what culture does is it institutionalizes and validates group beliefs, group values, group behaviors, and group attitudes. So how do I know that I'm not crazy? Because there's a whole bunch of folk over here who are like me who do exactly the same thing. Yes? And when we're all running into these institutional spaces, right? And we're about to lose our minds sometime, yes? Where do you go back to find who you are? Back to them cultural roots. You go to access family, you go access community, you go access those places. Well, your clients do exactly the same thing. But if you're going to help them, right, and be more culturally competent, what you've got to do is really understand what culture is at the deep structure level. Culture, then, is a complex constellation of mores and values and customs and traditions. But what does culture do? The second half of that phrase is what's most important. Culture provides a general design for living. and a pattern for interpreting reality. Let me say that again. Culture provides a general design for living and a pattern for interpreting reality. So, if I'm with Saladin, okay, I have my glasses on, okay. So, I'm an African American client in a room with Saladin. And he is working with me on whatever debilitation I have. Part of what he has to be able to do, if he is culturally competent, is be able to answer that question that says, what is my design for living? And what patterns do I use to interpret reality? What are the mores, the values, the customs, and traditions that inform and shape my perceptions of reality? That's what you have to do to understand culture. And I have to be able to understand the same thing in him. Yeah, that scares some people. Because in traditional training, what you get taught is what? To be this objective outsider. To not be into self-disclosure. To not share any part of yourself. And wonder why your clients don't come back. Because we aren't able to make these authentic connections. What I'm arguing here is that if you're going to understand culture, you cannot afford to understand culture and touch it at a distance. You've got to be able to embrace it and to be able to work with it. But the clinicians have to understand what is your client's design for living and pattern for interpreting reality. And the clients have to understand the same in the clinicians who are treating them. That's what I would argue. Y'all with me? Okay, let's continue. Now, let's put your scuba diving gear on. Because we're going a little bottom of the ocean deep here. Because I think that if we're going to understand culture, it's important to understand culture at the deep structure level. So there are 5 elements I want to introduce you to that ought to inform and shape the way in which you understand culture in the practice of mental health. The first is ontology. What are the ontological assumptions that you make, right, as a cultural being? In the language of your clients, understand what are the ontological assumptions. What is the nature of reality for your clients? Secondly, axiology. What is the value system? What are the axiological assumptions that your clients make? What are the values that they hold near and dear? Third, cosmology. What are the cosmological assumptions? What is the relationship between your client and the divine force in the universe, whatever they call him or her? If they call him or her anything, because some folk, right, don't have any belief system that way. Fine with me. But you need to know that. Fourth, you've got to know epistemology. What are the epistemological assumptions that they make? Meaning, what is their system for knowing, understanding what is true? How do they come to know and understand what's truth? Now, in the academy, since all of us are connected in some way, shape, or form through our degrees, affiliations, or where we work with academic institutions, what's our system for knowing and understanding what's true? Somebody tell me.
Empirical study.
Say that?
Study.
Empirical study, exactly. Scientific method. That's how we come to know and understand what's true. But a lot of cultural groups use lots of different things. So in the black tradition, Taisha Caldwell there, right, when she was back in high school, came home and said, I'd like to go out tonight and, you know, so-and-so's going to be there and the parents are going to be at home and blah, 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 and blah, 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 got all the rationale about why it worked. And she tried to get a permission slip to get out the house. And that makes perfect sense in those of us that are these rational decision makers, because you get taught to line up, right? All the pluses and the minuses, and kind of make sense. Except sometime mom or papa, sometime grandma was sitting in the corner and she would just go, child, I got a feeling. Yeah? Things just ain't quite right tonight. No, you can't go. Anybody remember that? What were they using? Scientific method? Intuition, instinct. That's that energy, that's that life force, that's the essence of spirit and spirituality that we're talking about. What is the system for knowing and understanding what is true? And the fifth element of culture I invite you to look at is praxis. Praxis. What is the system of human contact? Why is that important? Because sometimes the system of human contact is different and makes a difference for your folks. So let me borrow you. You are?
Alan.
Alan. Alan, step forward for me. So Alan is a client. Have a seat right there. So Alan's a client in the mental health center. So I then, get the paperwork back in my office. I come walk into the waiting room, and I'm saying, is Alan here? Okay. So Alan, you stand up. Now, how do we usually greet each other? Right? This is the system of human interaction. Right? Now, I'm going to transform Alan before your eyes. So I want you, because what population are we talking about today? What's our population? Somebody say African American. Right? Right. We're African American. So we're going to transform Alan into an African American. Right? Now, if you see two black men who would greet each other, how would we typically greet each other? Huh? So we might do something like this. That's a cultural violation. Why? That's an ethical violation. Thank you. Why is that? Not just because he's not African American, because he could be, white, brown, blue, and purple, and still do that. There are lots of white folk I know who do that. Because it's not skin color, it's cultural consciousness I'm trying to talk about.
Well, it's considered a violation when you're not supposed to touch.
You're not supposed to touch your clients, whatever, it's about exploitation, about whatever. See, understand where ethics come in and inform and shape what we do. APA ethics and ACA ethics, right? American Counseling Association, American Psych Association, have ethical codes that assume at a deep structural level that somehow people are about to exploit clients. Thou shalt not. So the ethical codes are a bunch of prohibitions about thou shalt not do whatever as a way of you gaining advantage in that particular context. In the ethical principles that I embrace, because I got to study and use them all, but I come from a tradition like the Association of Black Psychologists. My role and task is a healer. And as a healer, my job is not to exploit a client. My job is to be able to do what I think is most facilitative in the moment. So when a client comes up and wants to greet you like that, what are they doing? What is your goal in the first 5 seconds of an interaction with a client? Establish a rapport, connecting with them. You're not trying to be clinically sophisticated. You're not trying to exploit them. All you're trying to do is do something that is facilitative in the moment to allow them to make a connection to you as a therapist that you will have to achieve any clinical outcome. So I demonstrate some of these on some of the tapes that I make. Some for Alan Ivey, some I did one for John Carlson in the Masters of Psychotherapy series. Nice to be considered a master of psychotherapy, right? So I did one of these, kind of tapes for APA and them. And I got colleagues around the country. Daryl was just, I was talking to Daryl Sewell about, he was saying, when he shows it to a student, I'll go, oh. And then he tries to walk them through, right, what that means. But you have to be able to rely on different traditions to be able to work, because what you're trying to do in the moment is that. But because what we're arguing for is that the system of human interaction in an African American population may be different than it is than what's laid out in the Caucasian one, or an Asian one, or a Latino one. No, all one body is the same, even though you'll find similarities across lots of these. So if we're going to understand culture, what I want you to do is think about ontological assumptions. What's the nature of reality? Axiological, what's the value system that your clients embrace? Cosmology, what's their relationship to the divine force in the universe? Epistemology, what is the system for knowing and understanding what is true? And practice, what is the system of human interaction? And if you then take time in your staff meetings, if you take time in your professional development opportunities, if you take time in your book circles and reading clubs to then go and read some stuff, you'll be able to fill out these charts over time so that the practice that you engage in your mental health facilities will be better informed about what is indigenous to these particular cultural groups, what is more informative and facilitative for you being able to get, right, the outcomes that you want, because you in fact will be a little bit more culturally competent than when you first started. Everybody with me so far? Yes, no, give me something. Let me do just a status check. How we doing over here? Y'all good? Over here, in the back, y'all good? Okay. Questions so far? I couldn't have been that clear. Irvin?
Just, I guess it's sort of a quandary because certainly, you know, not all African Americans are going to embrace someone else.
Exactly like.
And not all Latinos are going to want you to kiss them on the cheek.
Right.
So, you know, I guess it's just intuitiveness. You just sort of figure it out when you're in that meeting. Is this the person that is going to be accepting of that? Is this a good way to make that overture or bridge? Or is it not?
Exactly right. So Irvin makes the point to say, of course we know that not anybody is going to be the same as everybody in a circle like that, or a square. Absolutely true. But remember what we're talking about in terms of cultural competence is just expanding your repertoire of experience and information. So that if you have the instinct that they're inclined to let you know. You ever walk into folk and everybody's in a friendly mood and somebody will just go like this and it's just like real weird because everybody else is hugging? You ever been there? Or everybody else is doing this and one person will just go, oh, you know, they'll let you know. But you got to be open and vulnerable enough to meet the clients where they are. Meet them where they are, not necessarily where you are. We're trying to meet their needs, not necessarily our needs as clinicians and providers. Yes? Okay, other questions? Okay, let's keep on pushing. So when we talk about some of the cultural differences, we're talking about working with black folk, billing for attorney, African-centered. What does African-centered mean? Because a lot of people think, oh, you know, it's some of that African stuff. It is not anti-white. Be very clear about that. The essence of African tradition is to embrace the human nature of everybody. I'll introduce you to the principle of consubstantiation in a minute. But what African-centered means simply is using African-centered principles, traditions, and a worldview as the lens through which our perceptions of reality are shaped and colored. Take African-American out and put any demographic you want. Latino, Asian, Indian, gay, lesbian, women, young people, whatever the demographic is, everybody has culture. Everybody has a design for living and a pattern for interpreting reality. What I'm arguing for is that we have to do a better job of expanding what it is we have learned about this, because most graduate schools and most continuing ed courses that you take are not teaching you this kind of stuff. That's what I'm arguing for. So, in African psychology, it examines processes that allow for the illumination and the liberation of the spirit. Where in traditional psychology are we talking about spirit and spirituality? Somebody say nowhere. Allow for the illumination and the liberation of the spirit. Why? Because whatever is in the first place spirit. There's a spiritual essence that permeates everything that exists on the planet. Bless you. When you talk about African psychology, what you're talking about is relying on principles of harmony within the universe. See the assumption. As the natural order, there's a natural order to human existence. Then what African-centered psychology recognizes is the spiritness that permeates everything that is. The notion that everything in the universe is interconnected. That is the ontological principle of consubstantiation. What is the nature of reality? Everything in the universe is interconnected. So if we are consubstantially related, then the fact that when you fill out the demographic form, what do you check?
Caucasian?
Caucasian. What do you check?
Yeah,
Caucasian.
American.
Okay. So, and I check African American. Consubstantiation tells us that if elements of the universe are of the same substance, that it doesn't matter that you are Caucasian, I'm African American, and she's Latina, and she's Asian. It means that we are all interrelated. The essence of that African tradition is in fact to be consubstantially related. But remember, there's a difference between the core of the theory and the way in which the theory gets practiced. So I don't argue that some people practice it differently, but that's what's core. Everything in the universe is interconnected. Third, the value that the collective is the most salient element of existence. Now, why is this different for us in academia? Because in academia, we teach our students that who's the center of the universe? Somebody tell me. And not just the students, but in psychology, in particular mental health, who's at the core? The individual. The individual is at the center. In these spaces, it's collective. And fourth, the idea that self-knowledge is the key to mental health. One of the best things you can do for the clients you treat is bring them into a knowledge of themselves. How many of you have strategies to do that in your mental health centers? How many of you have, right, even questions on your intake forms that even get at some of this cultural information? Anybody got one? Because I don't typically see them. So as we continue, I want to move through this real quick and just do a couple. Here's an example that I've used that talk about European American folk and African American folk. I don't want to suggest that all white folk are like this or all black folk are like that. These are just examples of what you can find. But I contrast them across these 8 dimensions: self, feelings, survival, language, time, universe, death, and worth. Okay? So let me pick 3 or 4 of these dimensions. The self in Eurocentric tradition is very fragmented and dichotomized. Any Freudian psychoanalytic folk in here? Who was trained in Freud? Everybody in psychology had some kind of Freud, yes? Freud argued there were how many structures of personality? 3. They are, anybody remember? Id, ego, superego, right? So that's like Psychology 101, right? Rote memory, right? And even Freud argued in this kind of difference equals deficiency logic, because he argued that there was one place, one province of your personality that you did not want to come out of. That was what? Somebody say the id. Because the id was the seat of all the destructive urges, right? And so if everybody acted out their id all the time, we'd be like all over each other. So what he argued in Civilization is Discontent, right, was that people had to what? Engage in a process of what? Sublimation, where you had to, right? Suppress, right, some of the energy, right? And channel that energy into what he argued were higher forms of human endeavor. On the African tradition, the self is much more holistic. So you not only have cognitive, affective, and behavioral, but I told you a minute ago, the most important element of that is what? Spiritual. And in this case, the knee bone's connected to the thigh bone. They're all interrelated. You can't have a change in one without having a change in the other. Much more holistic. Survival. Let me go with feelings for a minute. Feelings in the Eurocentric tradition are supposed to be suppressed and controlled. So we have these kind of emotionally controlled ways of being. We're about to go into midterm elections. And they won't start thinking about it now. Oh, that's not even true, because they're thinking about it now. Because there'll be prominent women who'll be running for, right, candidate in 2 years when we have the national elections, right? And even women will get excited about that for about all of 30 seconds. And then we start going, uh-oh. Do we really want a woman with her finger on the red phone? And even some women think like this, which is just disgusting to me. Why do we, right, have a stereotype sometime about women making decision makers good or bad? Because we think women are too what? Emotional. See, I would argue if we had more emotion in some of the decisions we make, we wouldn't be in some of the messes we're in around the world right now, right? I'm just, I'm just saying. But that's that feminine energy that men don't want to use too. We all have masculine, feminine energy in us. But the suppression and control of feeling is important in one side, but the expression of feeling, the vitality, the aliveness is what's most important in another. So all of you are my 3rd grade class. Y'all ready? Question for the day, class, is, in what year did Columbus get discovered by the Indians? Right? And so Johnny, but Rashid, I know, or Jose, me, teacher. What will a teacher in almost every classroom in America do? And I consulted a whole bunch of them. Right? Well, beside picking Johnny, right? Who's nice and calm. Better calm down, Rashid. Better cool out, Jose. And then if Rashid and Jose get to acting like that across too many time periods, the teacher got a little lightweight diagnostic tape going off in her head, usually her, right? Disproportionately female than male. Because now they're thinking that Jose and Rashid are what? ADD. Any wonder why a lot of referrals to the mental health centers that we get, right? Overwhelmingly, that come out of the school system are male, not female. And overwhelmingly, right? Kids of color. On something that they're just being excited about learning, because there's a cultural difference about how you express versus suppress and control feeling. All they're doing is being their natural selves. Survival. Eurocentric side, individual. The rugged individual. Be, right? Stand on your own 2 feet. Individual achievement. That's what we teach in our academies, yes? Except lots of folk come from communities where it's about collective survival. I introduce you there to an Ashanti proverb. The proverb simply says, I am because we are. And because we are, therefore I am. It means an individual is only important to the degree that he or she contributes to the maintenance and survival of the group. What you want is irrelevant. But you understand that as you then go to meet the needs in a reciprocal way, so too then do you get your needs met. Because what goes around, what? Comes around. But the rugged individual, here comes Mrs. Jones. So Mrs. Jones is in the mental health center today. African-American woman, 46 years of age. Well, Dr. Parham, I'm tired. Why are you tired, Miss Jones? Help me understand what tired means to you. Well, I'm tired because, I'm taking care of, my family. My husband, he's, been laid off a while and he's struggling, and depressed about being unemployed and, been using a little substance, whatever, and I'm working through that. And oh, by the way, then my mom has crossed town, and mom crossed town has, been bugging about some stuff, and I'm trying to work with her. And then, my brother who, works wherever, he lives across town, I'm trying to, take care of them. And then I have a sister across, on the other side of town. She lives right in the county, and I'm trying to work with her issues. And then, oh, by the way, I got my kids, and I know they're grown, but, you never leave your kids, and blah, blah. And you get this thing of Mrs. Jones, where her whole self is kind of wrapped up into taking care of other people. We got a nice diagnostic label for Mrs. Jones. What do we call her? Mental health practitioners. Say that? Codependent. That's exactly right. Got whole books on Mrs. Jones. Do you know how culturally laden codependent as a term is? Because codependency assumes that the individual is at the center of the universe. How do you tell somebody who comes out of this particular cultural ethos that you are codependent? And a single mom, right? Isn't that deep? One more, worth. Worth in our community is defined by material possession. So somebody could drive right down, this is what, Century Boulevard out front. Right down Century Boulevard. How would you know they were important? How would you know? Car they drive, clothes they wear, money they make, house they live in. If they valet park versus self-park, right? Ooh, they must be, right? We get to judge people by material possession and acquisition. I want to invite you to consider this afternoon that worth in other communities are not defined by material possession, but rather by contribution to the community. It's like that Janet Jackson song that said, what have you done for me lately? It doesn't matter whether Parham got 15 PhDs or what kind of car I drive. What they want to know is what difference did it make for the broader community that you were in this particular space and time. So you want to know why your students are so caught up into, right, doing a whole bunch of things for the community instead of taking care of themselves and doing some of the studying and other stuff, which leads them to have a lot of academic difficulty, yes? And our advice to them is what? You're not managing your time right because you got to stop and cut out some of this because you got to focus on this. Sound familiar? And how many of you know that in some of those cases we commit cultural violations without even understanding that it's a cultural violation? Now, I'm not suggesting that you can't develop strategies to help students study and prioritize, and maybe, if you're spending too much time over here in the community and not enough time in your book, then something's out of whack. But you got to talk to them in a way that says, look, understand the legacy of your community, but don't you understand that you can fulfill a legacy by being the smartest person in your class in the same way that you can by working in the black student or, METCHA or the Asian Pacific Student Association or the LGBT Center or someplace else. So you can still recite the same cultural traditions, but use it in a way that helps them reframe it in their head so that it doesn't seem like, oh, this person trying to get me to sell out. Because that's what they hear, even though that's not what you said. Everybody with me? So this is just a quick illustration to show you that if you contrast value systems on one side or the other across these dimensions, and there are a ton more, you can see how, in fact, you can have cultural difference in the way in which people interpret reality. This is just different value systems. I'm not saying better or worse, but this is how your clients, right, will come through you within the context of the work that you have. Okay, I'm gonna be moving quickly now. So point values are doubled. So I introduced you earlier to this particular space. This is the step pyramid at Sakata. It was built by the pharaoh Zoser back in 17 BC. I should say it was built for the pharaoh Zoser. It was built and designed by the architect Imhotep. Not the Imhotep you see in the mummy movies, skeezing on the pharaoh's woman kind of Imhotep. I'm talking about the genius Imhotep, first physician architect on the planet. But I think that this particular structure, 5,000 years old, symbolically represents the building blocks of cultural competence. So I'm going to try to walk you through those as an invitation to think about being more culturally competent. The first thing you have to have is strong conceptual anchors. So you got to have conceptual anchors that have a strong belief in the possibility of human transformation. What theories are you embracing in your mental health practice that fundamentally believe in the possibility of human transformation? I'm not talking about pathologizing people's behavior. I'm talking about human transformation. The alchemical process of human transformation toward perfectibility. What does it say? It says, I be in the moment. But while I be, I'm always in a state of becoming more better. Human transformation. Secondly, you've got to have a strong foundation and belief in some kind of theoretical and conceptual model of helping. You got to have a theory, because your theories are the roadmaps that you use, right? That make assumptions about what's going on with a client, what's the nature of distress, how, why do people change, what's the role of the therapist in treating them. Theory has to anchor what you do. I'm simply arguing that your theories have to be more culturally based than they probably are now. And you've also, as we've talked about today, got to have knowledge of culture at the deep structure level, not the surface structure level. The second element that you got to have in the building block are values. Ancients built for eternity because they had values that were aspirations to harmonize with divine intent. They had values that were about the cultivation of the human spirit and elevated human consciousness. And there were strong ethical standards that were culturally based that anchored what all the ancient societies did. In African tradition, they understood the ethical principles of Ma'at, M-A-A-T. That was the system of knowing and understanding the values that really they anchored their work in. But your building blocks of cultural competence have to be able to have values in them. Now I'm going to move through the ethics quickly so I can get to the skill piece. Third dimension you got to have is what we call competency dimensions. Now I told you about the competency models. They didn't start with skill. Teach me the one thing I can do, 5 things I can do technique-wise to be better. They didn't start with knowledge. What's the one book I can read? What we started with when we first developed these, Daryl Sue and myself and Patricia Redondo and Rod McDavis and Alan Ivey and Patricia and Michael DeAndre and all the folk who've done all the competency work that you read, is we started with awareness. How do you become aware of the biases and assumptions you bring with you into those clinical spaces that you occupy every day? Awareness. The second piece, knowledge. How do I then inform myself about a group's history and culture? The within-group variability and the between-group difference. What are the differences and how do they manifest themselves in terms of cognitive, affective, behavioral, and spiritual dimensions of personality? And then the skill, how do you, illustrate particular skill in managing some of the client bases that you work with? If you lined up 4 clients in this front row, 5, and I have one who's white, one who's black, one who's Latino, one who's Asian, one who's Native American. and I put most clinicians in front and I say, show me how your therapeutic approach would vary based upon working with each of these folk if you're trying to be culturally competent. How many of them you think could pass that test? If you gave this test to people on your staffs, how many of them, even with all their degrees and certifications, could pass this test? If they can't, guess what? There's an invitation there for some professional growth and development. How many of them could give this lecture I'm giving you now without blinking? If they can't, this is basic knowledge that folk ought to know in working with African American populations, or Latino populations, or Asian populations. You got to be able to have the skills to be able to get to that. Now, when I talk about competence, I want to go back to the assumption I made about, right, we're moving from competence to proficiency. So if you're keeping notes, I want you to write these down the left side of the page. I think you can actually have incompetence. There's a lot of that out there in the world. Incompetence in this case is I lack the awareness and I don't have the skill. Incompetent. You can have precompetence, meaning an individual possesses the awareness that competence is important but lacks the skill to implement or achieve any of the clinical objectives that he or she wants to achieve. Precompetence. You certainly have competence, which is I possess a set of skills and attributes that allow them to effectively intervene on the demands of a particular situation or circumstance. I have the awareness and the skill. And then, of course, I'm trying to preach proficiency now. So when I talked about this in this article with the California psychologist, I talked about proficiency possessing the ability to reflect a high standard over time. That means I can consistently do what I want to do and I can achieve what I want to achieve with a client and do it with a standard of excellence. Now, what I invite you to do is to think about drawing a line on the top of your page going this way at 45-degree angles. Because I think you can list particular skills that you have to illustrate in working with clients across the top. Because competency is not something that you do that is an all or none proposition. It's not I'm either competent or I'm not. What I'm trying to do is break our mental health practice down into little bitty micro skills. So when I connect with a client like Irving, I might be real competent. Might even be proficient. But when it comes to using appropriate culturally based assessment instruments, I might be incompetent or precompetent. I'm aware that what I'm using ain't working, but I don't quite know. When it comes to me facilitating awareness and using culturally based models to be able to facilitate awareness of folk, right? I might kind of be bordering between pre-competent and competent. Okay. When it comes to setting goals or taking action and instigating change, I might be real proficient. What I'm arguing is that it's not an all or none proposition. So that if you look at incompetence, precompetence, competence, and proficiency, and look at across different skills that you would illustrate, you may in fact have different categories that you're doing very well in and some you need to work on, as will anybody on your staffs. So as you're thinking about developing a chart out of this, develop a chart that allows you to look at the individual skills across these particular domains of competence. I invite folks to remember, this is a page in a 2002 book I wrote on counseling persons of African descent. And the publisher wanted to know why I wanted to spend a whole page in the book. So the first page of the book says nothing but this, because that's the message I wanted to send. I wanted to send a message that said, healing is therapeutic if you can heal. But not all therapy is healing. Healing is therapeutic, but not all therapy is healing. So we can employ different therapeutic strategies and techniques. It doesn't necessarily make them healing just because it's called therapy, particularly given the populations that we're trying to work with. So if you think about therapists as a healer, therapists, right, are healers. And healers are people who participate with clients, not on clients. Let me say that again. They participate with clients, not on clients, in trying to help confront some of their mental, emotional behavior and spiritual debilitations. What does a healer do? First of all, a healer has to heal themselves. Heal thyself. Second, remember the past. How have you yourself been impacted, and what are the kind of residual things that are going on in a client's life that might impact where they are in the moment? Healers have to be able to access the spirit. I'm not talking about spirituality in a religious sense here. I'm talking about that spirit, that energy, that life force, right? Joe White was talking about how he could just see the gait of the student just kind of change after a while. He only worked with him about a couple sessions. And he knew it wasn't just related to what he was doing here. It was related to them getting out in the environment and engaging people in a more meaningful way. Finding a boss sister at a party. And confront the Maafa. Maafa, Kiswahili word that means a great disaster of death and destruction beyond human comprehension and convention. But big explanation. The chief feature of Maafa experience is the systematic denial of someone's humanity. So when you see people go through these microaggressions, as Daryl Sue calls them, as Chet Pierce first framed them when he was at Harvard way back in the early 80s, what we're talking about is what are those kind of microaggressions, micro-assaults, micro-invalidations that dehumanize people. And you have students who go through situational phenomena every day on your campuses and in your communities where they feel like they are populations at risk. Why? Because they're just these little things that just nag and pick at them. Yes? Who's been there with the students? Yes? That's what Maafa is. You got to be able to understand that there are these things that invalidate their humanity, and we got to be able to work with. But you as healers can't just rely on your degrees and I'm qualified. You got to be able to subdue pride. Healers have to be able to subdue arrogance. Healers, like their clients, have to be able to aspire to perfection, and healers have to be open to all. The building blocks continue. That you've got to talk about domains of advocacy here. And in the domains of advocacy, I was suggesting in my remarks this morning that some of the problems that people have are not in fact just intrapsychic, but in fact are social, cultural, and environmental. So if I'm a client who comes in and I'm depressed, I'm anxious, I'm angry. I'm a woman who's been sexually assaulted. I'm a black student who's run into some bigotry. I'm a Latino student who's been talked down to in the classroom. I'm a Asian student who is not feeling comfortable in my particular space. It makes sense for them to be angry and anxious and guilty and all those other things that they come in with. But if they come in being depressed and to see people like me, and I can help restore them to some level of health and wholeness, I can help treat them in whatever my repertoire is to treat people who are depressed and anxious, having adjustment disorders. And I can help them to feel more mentally healthy. Really all I've done individually is help them to feel more mentally healthy and then sent them back out into the world still vulnerable to the same social pathology that wound them up in my office in the first place. So what we argue in cultural competence is that our competency domains have to extend beyond the individual so that we have to be able to impact institutions. We got to be able to impact organizations, and we got to be able to impact the society as a whole. That's where your advocacy has to be able to take place, not just individually, but institutionally, organizationally, and society. And these advocacy competencies I'm talking about are the ability to understand and carry out, advocacy on the part of your clients to help them take some action to be able to change their condition. So if they're having difficulty with professors, then we got to advocate to the academic side of the house. If they're having difficulty with law enforcement, then we got to advocate on their behalf. If they're having difficulty with whatever, we've got to be able to be advocates for them in that particular space. And this is one of the charts I borrowed from my good friend Daryl Sue, who talks about this same dimension. Individual is what we focus on most. But we want to invite you to think about organizational, institutional, and societal competency as well. Lastly, we talk about liberation. And liberation in this case becomes liberation of the intellect, emotional liberation, behavioral liberation, and spiritual liberation. The building blocks of cultural competence require that we get through all those. So what do we need? We need strong conceptual anchors. We need a good set of culturally based values. We have to pay attention to the competency domains, domains of advocacy, and ultimately to achieve some level of liberation. We started this presentation today. I had 3 goals. The first goal was think about being a little intellectually provocative. Hopefully we've been so. Yes? Second, I want to be emotionally stimulating. Kind of get you to believe that, yeah, we can really, right, do something about this. But third, and perhaps most important for me in doing workshops like this, is to get you to think about making a commitment to do at least one thing differently than you were doing before you walked through that door this afternoon. If we could do one thing differently in your repertoire to help be more culturally competent and then begin to build on that, that's how I think we're going to engage in, right, a better practice for the people that we are, right, sworn to serve. So I close with these 2 thoughts. An opportunity, my friends, is a threat. An opportunity to be more culturally competent is a threat if you only predict failure. But it's a challenge if you think we just might win at this. Who thinks we can develop different levels of cultural competence? Yes? Who thinks we can be better than where we are? And what I want, right, my humble request for you is not to be 100% better on 50 things. That's too big. That's like that New Year's resolution we make and then nobody remembers what you promised 2 months later. Yes? I don't want you to be 100% better on 50 things. I simply want to ask you, can you think about being 5% better on one dimension of cultural competence? Whether it's African American, Latino, Asian American, whoever the group is. Women, gay folk, doesn't matter. Disabled folk, fine with me. Can you be 5% better on one dimension of competence? And if we added up all the 5% in the room, in your institutions, we could literally transform our institutions overnight. Who thinks they can give me 5%? Can y'all give me 5%? An opportunity is a threat if you only predict failure, but a challenge if you think we just might win. With that, I'll stop and say thank you. It's been my pleasure. Thank you for being here.